Welcome to Breakthroughs. I'm Erin Spain, Communications Director at Northwestern University Feinberg School of Medicine. Glioblastoma is one of the most common and aggressive brain cancers. The median survival rate is just 15 months. To better understand and treat glioblastoma, Northwestern is building a robust brain tumor research enterprise with a unique focus on this disease. Today, we're talking about promising results of a phase 1 clinical trial that uses immunotherapy to treat glioblastoma. Dr. Rimas Lukas, a co-author of the clinical trial, which is now in phase 2, is here with details. He's an associate professor of neurology and a member of the Lou and Jean Malnati Brain Tumor Institute here at Northwestern. Welcome.
Thank you for inviting me.
Tell me a little bit about what we know about glioblastoma. The disease often makes headlines when a high-profile person such as John McCain is diagnosed, but it's about 12,000 Americans every year are affected. How does this present? How is it diagnosed, and what treatments are currently being used?
Most of the patients we meet typically come to us in a normal, healthy state, and then this sort of pops out of the blue. And usually there are two types of presentation. So one are the localizable symptoms and the other are non-localizable symptoms. When we talk about localizable symptoms, we're speaking about problems that arise, symptoms that arise based on the neuroanatomic location of the lesion. So if it's in the motor strip, they may have weakness on the opposite side. If it's in a part of the brain that's involved in language, they may have difficulty either comprehending or expressing themselves. In addition to that, we may have non-localizable symptoms. And the non-localizable symptoms are due to increased intracranial pressure. That typically manifests as headaches that are usually worse when you're lying flat, oftentimes present when you first wake up in the morning and sometimes even awaking you from sleep. These headaches may be accompanied by nausea or vomiting and double vision. In addition to that, patients may have some cognitive symptomatology in association with these headaches as well.
And so they're usually referred to a neurologist. That's how they end up seeing you?
Not necessarily. I think the most frequent path that patients take is they're, again, a healthy individual and they develop these symptoms. Maybe they also develop seizure activity, and then that leads them to an ER locally. Imaging is performed, and that imaging reveals something which is of concern. That's probably the most frequent pathway. I think the other one that we sometimes see is patients present to their primary care provider with these symptoms, and the primary care provider either refers them to a neurologist or to imaging and then the ER pathway.
And so it's diagnosed, then you do the imaging, something looks like it could be, and then you go in and explore through surgery?
Correct. So the imaging that's typically performed in the ER, the first thing that happens is a CT scan or a CAT scan. It's imaging that uses X-rays to take a look at what's inside the brain, and we may see an area of abnormality. It's kind of the quick and dirty. It's the Polaroid that just gives us a flash of what may be going on. That's typically followed up by an MRI scan, which provides much greater detail with respect to what we see. Ideally, that MRI scan is performed with contrast dye, so a dye is injected into the veins, fills up the normal blood vessels, and in certain places it leaks out and makes things bright. Individuals who have comfort and experience in evaluating these studies, and that can be your neuroradiologist, that can be your neurologist, your neurosurgeon, may see the images and have concern for a tumor as the underlying explanation. In turn, that will lead to the surgical intervention, which will both, one, establish the diagnosis, and two, be therapeutic when tumor is resected.
And then from that point, the typical therapy now that someone may undergo, there's usually 3 different parts. What is the normal regime here?
So the standard therapy would begin with surgical resection. And in general, the belief is that cutting out more is better. So the larger percentage of tumor that you can get out, probably the better it is for that patient. It creates space. It debulks or cytoreduces, means removes tumor cells. And then in novel approaches, as we'll discuss a little bit later, you can use the surgical intervention as a way to deliver another therapeutic. After the surgical resection, which patients typically recover from fairly quickly, much faster than they do from abdominal surgeries and chest surgeries, they'll ideally meet with a neuro-oncologist, such as myself. We'll talk to them about what those next steps would be. That usually entails focal fractionated radiation therapy, and focal meaning pointed at the area of interest plus some margin. Fractionated meaning broken up into days, Monday through Friday, repeated over and over again for a handful of weeks. And in addition to that, we usually administer a chemotherapy drug called temozolomide, commercially known as Temodar. It's a pill that they take usually on a daily basis during that time frame. After that's completed, they have about a 1-month break where they're off all therapies. A new imaging study is performed, and that imaging study is utilized as the new baseline, and there's a reasonable chance that they may have false growth of tumor on that scan, what's called pseudoprogression. At that point in time, we typically begin with cycles of the Temodar chemotherapy, usually taking it for 5 days out of the month for a handful of months. The other therapeutic modality, which we should mention that's viewed as part of the standard of care by many, including our group, is the utilization of something called tumor treating fields. These are electrical fields which are created by a set of arrays which are placed directly on the scalp. These arrays create these fields, and when things that have polarity are put within electrical fields, they get moved around. The mitotic spindle, which is the framework upon which the tumor cells set up their genetic info to divide to make more tumor cells, is composed of a large number of polar components. When they're within the electrical fields, this leads to disruption of the mitosis, slows down the turnover of the tumor cells, and also leads to tumor cell death. So that's the sort of the standard package of how we would treat these tumors.
That last one you meant, what does that look like? Are there something that's attached to the scalp, or?
It is. So one of the primary drawbacks, or the primary drawback of utilizing that modality, is that you have to have your head shaved completely, and then you tape it onto your scalp. And it's a set of arrays that are on a sticker, kind of like an EKG sticker, and they're applied directly to the scalp. There's a set of wires that run down the back to either a battery pack when you're out and about in a kind of a nondescript gray carry-on bag, or plugged into the wall when you're at home.
But yet, so you have the standard of care, but so many people do end up succumbing to this disease. Why is glioblastoma so hard to treat?
Yeah, it's an excellent question. It's the multi-billion-dollar question that we don't have an answer to. Why do our treatments fail? And this is something that our group here at Northwestern is particularly interested in, right? So we have this track record of therapies that have made incremental gains. Surgery has improved survival. Radiation has improved survival. Temozolomide has improved survival. Tumor treating fields have improved survival. Yet we don't know why any of those things fail. There is work being conducted by Craig Horbinski, who runs our molecular neuropathology laboratory, which I think is really going to, from my perspective, hopefully revolutionize our understanding of why these things fail. Atika Med in the neurosurgery department is also doing work focusing on why temozolomide fails, why our treatment for the past 15 plus years stops being effective in the majority of patients after some interval.
So you mentioned just two different investigators. We have many different investigators here at Northwestern all working at the same time on glioblastoma in different ways, different areas. Share a little bit more about what we are doing here to sort of attack this cancer.
Sure. So I think, we're not putting all of our eggs in one basket. Yeah. We have, I think, a very diverse and complementary portfolio. And I think this is probably best encapsulated by the SPORE, Specialized Program of Research Excellence, NCI grant projects. This is a very large kind of master grant that provides a framework for conducting numerous studies, clinical and preclinical studies, attacking the problem of glioblastoma. It's composed of 4 separate projects. And in addition to that overall arching framework, we have numerous other projects and numerous other investigators all working with one another to try to solve this complicated problem.
I know we're using nanoparticles, viral therapy, immunotherapy, which is something I want to talk a little more about. It has to do with this new clinical trial that you're working on. Talk to me a little bit about immunotherapy. What happens to the immune system when this type of brain tumor appears, and how does immunotherapy change that?
Sure. So the immune system is what the body has to fight off all the bad things, right? It can fight off infections. It can fight cancer with this. And within the context of many cancers, the tumors themselves create a immune-suppressed tumor microenvironment, meaning that within the tumor itself, the activity of the immune system is dampened down. Within the context of glioblastoma, we also have a more globally suppressed immune activity, which is interesting because this is a small organ that's located separate from everything else, but yet it's somehow sending signals that dampen how much of a specific type of white blood cell is present even within the normal blood of an individual at the time of their diagnosis. Now, what happens within the tumor itself is that the signals for dampening things down become very robust. And there's one that our group is particularly interested in. I've been working very closely with Derek Wainwright in the Department of Neurosurgery in his laboratory, which studies an enzyme called IDO. IDO plays a role in converting the essential amino acid tryptophan into a bunch of other things. One of those things that it converts tryptophan to plays a role as a master regulator for dampening immune activity locally. So it causes all the problems that we don't want to occur within the tumor. So it leads to an increased amount of Treg cells, which are immune cells that further dampen activity. It leads to increased expression of something called PD-L1, which is kind of like a set of brakes for the immune system. And it leads to a lower amount of CD8 cells, the cells that are aggressive that we want present to help kill cancer cells. So working with Derek's lab, his group had done an extensive amount of preclinical studies, meaning in non-humans, in animal models, at differing approaches to address this problem of local immune suppression. And what his lab has been able to demonstrate is that when mice are treated with a combination of radiation therapy, immunotherapy with suppression of that IDO, and the addition of what's called a PD-1 antibody. These are commercially available to treat other kinds of cancers like melanoma, lung cancer, bladder cancer, etc. When that triple combination therapy is utilized, you can get very robust, sustained responses in these animal models, meaning that we can cure some of these animals of their brain tumors, which is exciting.
Wow. Yeah,
and then even when those animals have recurrence of brain tumors, we're able to cure them again. So the immune system still remembers how to do it. This is exciting for us because we have just recently opened this within the context of a phase 1 clinical trial here. This is part of that SPORE project that we spoke about. This trial is going to include a number of correlative studies that are going to be conducted by the Wainwright Laboratory. So looking at having a better understanding as we move forward with this treatment, why it works in certain scenarios, why it doesn't work in other scenarios. We'll also be collaborating with colleagues in nuclear medicine with regards to advanced imaging studies using something called AMT PET, where we can actually image that tryptophan metabolism. So it's pretty exciting for us.
So that's a phase 1 clinical trial that's just getting underway here.
Correct. Yes.
Wow. Okay. And what we're here also talking about is now a phase 2 clinical trial that you're working on that's
Correct.
with a different set of approaches. I'd love to hear about that and where we are with that.
While the other treatment, we're sort of removing the brakes on the immune system, and then we're also playing with the transmission. In this approach that was just recently published, the phase 1 dose escalation study was published using gene therapy to really step on the accelerator for the immune system. And what happens in this study, published in Science Translational Medicine a handful of weeks ago, was that surgeons resect tumor in the recurrent disease setting. Intraoperatively, they inject an adenoviral vector, so a virus that brings a gene into the tumor cells. We can then activate that gene with a pill that the patient takes. When that gene is activated, it leads the tumor cells to transcribe IL-12, which is a cytokine or a signal that really steps on the accelerator for the immune system. Now, this type of approach done systemically, meaning giving patients intravenous IL-12, has proved in the past very difficult because it's not tolerable from a practical perspective. By doing this locally, where we really need the immune system to be activated, we think that it can be much better tolerated. And by using a gene therapy with an on-off switch, we can stop it and start it as needed. So if it becomes problematic, you just turn the gene off and it stops making what you want it to make.
And you turn it off you stop taking that pill.
You stop taking the pill.
That's it. And and the virus that you mentioned, how you're sort of getting it in there during surgery, that's a virus that doesn't really harm the patient.
Correct. So it's the cold virus that we're using. So it's something that patients seem to tolerate well. In the published paper, we're able to demonstrate, 1, what the optimal dosing of that pill is, 2, that this can be done safely, and then 3, which for me is the most exciting, is that this concept works, right? Because this has 50 moving parts to it.
Right.
And I think it really relies on the expertise of very subspecialized multidisciplinary team, which we're lucky to have here at Northwestern. But everything has to kind of come together. And in this case, it did. And we were able to demonstrate that we can turn that gene on, that it can make the product that we wanted to, that it can make the downstream product that we wanted to, that if tumors are sampled later that we're having the effect that we want, the infiltration of those CD8 cells, the cells that are going to help kill the tumor weeks after we stopped turning that gene on. So it's pretty exciting.
I saw some pictures from the paper. It's almost like you can see the immune cells, like they're glowing on the tumor.
Yeah, in that figure that you're alluding to, the images are stained to look for that specific type of immune cell. And if you look at the original sample from the time of resection, you see that you don't have those immune cells present at all. So these are the cells that kill the cancer. And then you look at the next one, you see that they're all in there.
So now here you are at Northwestern, you're in phase 2. Have you already performed this on some folks here that are in the clinical trial?
That's correct. So there are a number of patients who have been treated thus far within the context of the phase 2 study. The phase 2 study is interesting because it adds an immune checkpoint inhibitor. So I mentioned those earlier. That's removing the brake on the system. And so here we're stepping on the accelerator and removing the brake. And in the preclinical models, meaning in the non-human studies, this has been demonstrated to be even more efficacious. And so we're hoping that we see that recapitulated in the humans.
How many folks have you recruited here in Northwestern?
At this point in time, we're at 3 patients who have been recruited out of approximately a 30-ish patient study.
Okay, because you're working with these other centers across the country. But to that little glimmer that you saw in talking about seeing that activity, from how does that make you feel as a scientist, an investigator, to actually see all these pieces of the puzzle coming together and working?
So it creates a spark of hope that in this disease, which has been extremely difficult to treat, that we have the potential to make positive impacts, right? And thus far, we've had very incremental gains, and they've been important gains. So improving survival by a little bit, and then improving survival again by a little bit is important. And seeing some patients who are just long-term survivors is important. If we can kind of keep just pushing the bar further and further, I think that's what makes this all worthwhile. And, hopefully we hit a home run and, something like this turns out to be very successful. But I always have cautious optimism when contemplating these types of approaches, particularly when it's very early phase.
So you mentioned 2 separate clinical trials. Are there other clinical trials you're working on at the same time?
We have a busy clinical trial portfolio. We try to be very thoughtful about it, and we involve the input of all of our colleagues within the Brain Tumor Institute. And so when we decide as a team to move forward with a clinical trial, we want the buy-in from the medical neuro-oncologists, the neurosurgeons, the radiation oncologists, the neuropathologists, the neuroradiologists, everyone to agree that this makes sense for our patient population, that this is something that could be beneficial, that there's a high likelihood of success, that we'll all learn something new from these endeavors. So we have a lot going on, and we have, I think, a portfolio that's well balanced from investigator-initiated studies, meaning things that have arisen directly from the individuals here at Northwestern, many of them directly from the laboratories. And some examples that I'd mentioned earlier was the collaboration with the Wainwright Lab, which just opened up using an IDO inhibitor. We've had other examples where we've utilized a gold nanoparticle to help treat these tumors, working with Alex Stieg and Chad Merkin's laboratories. And then the Matt Lesniak laboratory using neural stem cells loaded with oncolytic or cancer-killing viruses are 3 homegrown projects which we've been able to bring into the clinic. In addition, we have other projects arising from other concepts that are not directly developed here at Northwestern, and then other projects that are industry-sponsored or cooperative group-sponsored.
Yeah, how unusual would you say this focus on glioblastoma is, though? I know there's probably other centers around the country, but Northwestern is putting a lot of effort and energy into this one disease.
So I think there are other excellent centers throughout the country and throughout the world looking at this specific disease. I think here at Northwestern we have a very unique group of individuals who are excited about working together as a team. We have a skill set which allows us to take the concepts developed within somebody's laboratory and bring them into the clinic, which is the dream of all medical neuro-oncologists such as myself, but it isn't feasible at most institutions. We're able to take these things, bring them into phase 0, phase 1 studies, and we have the expertise that carries all the way across through phase 3. So our division chief, Roger Stoop, is the individual who served as the principal investigator for the 2 trials in newly diagnosed glioblastoma that demonstrated improved survival and that led to FDA approval of temozolomide, the drug, which is our workhorse chemotherapy, and Tumor Treating Fields, which is the most recent advance that has received FDA approval.
Well, how did you find your way here to Northwestern? From the time you went to medical school to now, did you always know you wanted to go into this specific area?
I think this field of neuro-oncology is really exciting because it is something that has a large sort of black box within it, where we don't know a lot and we need to know a lot. I think the stakes are high. And my anticipation is that during the course of my career, we will learn a lot and make positive impacts on it. So I think that aspect is a strong driver for wanting to do this for a living day in, day out.
Thank you so much, Dr. Rimas Lukas, for coming and joining us and talking about both of these exciting clinical trials taking place here at Northwestern.
Thank you.
A note to all of our listeners, did you know that Breakthroughs is CME credited? Go to our website, feinberg.northwestern.edu, search CME, and start taking some of the courses and claim your credit. I'm Erin Spain. Thanks for listening.